Early palliative care for older people with multiple health conditions, learning from illness trajectories. Most people in economically developed countries now follow one of three illness trajectories towards the end of life. Acute decline, typically progressive cancer. Intermittent decline, typically heart failure or COPD, or a gradual decline from a lowish baseline, typically in old age or dementia. However, older people with multiple conditions may have dips in their gradual physical trajectory of decline due to accidents, pneumonia, or hospital admissions. But apart from the progressive physical decline, people have predictable psychological, social, and existential needs. Dying is indeed four-dimensional. So in older people, how might the psychological trajectory progress? Well, there may be anxiety or depression associated with a physical dip, or worry about getting dementia, or being admitted to a care home. Social concerns may include not seeing friends, especially when acutely unwell, or not getting out, or feeling they are a burden to their relatives. Existentially, well-being may suffer if someone is unable to do what they used to do, and a feeling of loss of control may make someone lose their sense of meaning and purpose in life, causing agitation and distress. So to adopt an individualized approach in people with multimorbidity and palliative care needs, we propose a three-stage network. Firstly, early identification. Secondly, multidimensional assessment. And 3, plan and communicate. So understanding these frequent concerns and likely patterns allows us to identify early by proactively screening when a patient might benefit from more comprehensive care. This allows us to detect people with early palliative care needs during the so-called first transition and start advanced care planning early, before reaching the second transition of imminently dying. Then we must do an individual assessment to 1. Check in what dimension there may be problems or difficulties, and 2. Perform a situational diagnosis. That is, at what stage of the trajectory is this person? Is it A, B, C, D, E, F? Then it's time to anticipate patients' concerns about how the illness may progress and help the patient, clinician and family plan together, often in the face of great uncertainty, to meet the patient's and carers' wishes. This three-stage framework is an essential part of personalising care, regardless of whatever tools are used by primary care, palliative care or geriatric teams. To identify a patient early, some clinicians find the surprise question, which is this patient sick enough to die, useful? Or specific tools to help trigger this. Assessment can be aided by various primary care, palliative care or geriatric tools. And planning can use a number of tested formats or names that should be acceptable to patients and communicated electronically. So, the take-home message is that as a patient's health declines, distress in any dimension should trigger an assessment and plan to increase care and prevent suffering. We can do this both in the community and in hospitals using whatever screening tools and opportunities arise. If patients have discussions and planning based on their likely multidimensional illness trajectory, their quality of life and dying will improve. This can reduce distress while promoting a realistic understanding of normal aging. These trajectories highlight the likely course of events and predict patterns of distress in all these dimensions. But palliative care seeks to actively prevent or minimise suffering and aims to maintain and maximise health in each dimension. Thus, we aim to help people sustain trajectories of well-being and die existentially at peace, without feeling unduly depressed or anxious, or having social or family problems, as we show in this last figure. This is early palliative care in action.